It is one of my first rodeos, but yeah. Hey, Doc, how are you? You
Hey,
get
good.
younger every time I see you.
Well,
Okay,
I shaved my beard, which is looking more white. So,
oh wait, no, you look good. It looks good. You've got five right now, counting you. We are recording, and they're going to put on our website because we're doing continuing education with it too. You may take over the screen and do slides because I have made you co-host, so you're free to roam. And if you need help, I'm right here. And Eric is on too, helping us if we need it.
I'll go ahead, get my screen share going here.
And we're going to give people a few minutes to jump in, whoever's coming. And then I'm not going to do a bunch of introduction on you because having listened to all your podcasts, I know that your story is part of this. And it's a very, very interesting, impressive, and moving story. So you get to tell it.
All right, thank you. All right, we'll wait a few more minutes. And can you all see my screen?
Yes, looks great.
All righty.
I've got like,
Dr.
I've got,
Barr,
Hey, Eric.
you are sharing your presentation screen
Hmm?
and you're sharing your presenter screen, not your presentation screen. It's fine.
Oh, yes. Thank you for pointing that out.
Yeah.
hit slideshow, I think.
No, it was just I've got two screens, so I
Oh,
shut.
gotcha.
Let's see.
Dr. Barr, how do you feel about having two screens?
I needed it because you've what is crazy is I built this practice on a laptop. And at 6'5", a laptop and sitting at a desk isn't exactly the best position to be in.
You're
I
really 6'5"?
hmm Dr. Denbar can vouch for that.
So very good. I have another question, which is what would you recommend for Dr. Denbar? Because he's debating whether he wants two computers or not.
I think two screens is good. I've enjoyed it.
He
Uh,
needs it.
let me share the right screen here because I think I'm sharing the wrong screen. So yeah, it's just my posture because I kept looking down, and this just allows me to look up and gives my neck a little bit of a break. Let's see.
Yeah, we in almost every area in our office now we have two screens. And I don't know how Dr. Denbar does it with one.
You all
But
see my desktop, and do you see my presentation coming on right now?
yep,
Yeah, perfect.
All right, and then does that work?
beautiful.
Is that right, Eric, as well? Is it still the presenter screen or is
No,
it?
no, you've got the
Perfect.
slideshow on. It's perfect.
Okay, all right, perfect.
Perfect. Perfect. We're just going to give them
Ah,
a couple minutes. In case y'all are jumping on, this is Texas Dental Sleep Solutions Study Club number 6. And I'm Dr. Jennifer Hathaway. Eric has deemed me the chairwoman of study clubs. And so I do it not begrudgingly, I do enjoy it. And we're going to just talk for just a couple minutes. Dr. Avi Bhar, who many of y'all are probably already working with, he is the pulmonologist extraordinaire who came up with his own telemedicine company, Sleep. And I've even heard him say it, Sleep, SLIIIP. So he says it really fast. But it's super cool. We will do a little housekeeping at the end, but Dr. Barr is on East Coast time. And so we want to let him talk and have Q&A, and then he can go play with his family, and we will do our housekeeping and anything else we need to cover then. All right, Eric, I think I've got everybody in. I'm going to let Dr. Barr start talking about himself. Does that sound good?
oh, I love that. That's a good start.
And I'm gonna hide myself. So if you need me, I'm still gonna be here. And
All
just
righty.
all
Well,
right.
let's go
Oh,
ahead
there's
and kick
Doc.
things off. Thank you, Dr. Hathaway, for inviting me, and nice to see you all here, Eric, Martin, Melody, and Charissa. Again, my name is Avi Bar. I'm a sleep, pulmonary, and critical care physician. Though my wife, I think, just told me today that I've retired from critical care and pulmonary, and that's pretty much fair because this is all I do. It has surprisingly become my passion. I love the ICU. I love the adrenaline rush. But more importantly, I loved the fact that in critical care, you had no choice but to be very methodical in your thoughts. You have to kind of be really understanding of where to break down the case, focus on the thing that's gonna really affect the patient, solve that first, and then everything else can wait, and then you'll handle the rest of it. So I think, I've taken that same mindset with everything else that I do, and trying to figure out what the underlying problem is. Because I think as clinicians, we tend to get distracted. Um, when we hear certain terms, we've got this algorithm in our heads. Like, oh, if I hear fatigue or I hear insomnia, I'm going to go down this different pathway because I already have a set algorithm of things I need to do. And I think just breaking down what the patient says. Patients are not lying. They're just using their own words to describe the experience in their best way possible. And I've fallen in love with sleep because it's amazing to be not only a clinician, but sometimes a magician as well, where you can fix stuff and lift the blinds off patients. I've just patients have described like, oh my God, I feel like I can see. I've been wearing sunglasses my whole life, and now I can finally see clearly because my sleep is so much better. The topic of the talk today is on sleep apnea, but also insomnia, because I think a lot of times, if you don't cover insomnia, you're missing out on an opportunity for a lot of women's sleep issues. And not to say that insomnia itself is the topic, but insomnia can sometimes masquerade as a symptom or it can be the diagnosis. And patients being patients, they will interpret things in their own perspective. And they understand that if you don't sleep well or you wake up a lot, oh, that's insomnia. And unfortunately, in the hands or in the ears of a clinician who may not be skilled, insomnia then goes down this pathway of I'm going to have to drug you to sleep or I have to kind of put you on CBTI, but not really understanding that they may have other clues that might lead the insomnia to actually be a symptom and not a diagnosis. So just a little bit more about myself. Fellowship trained. I am glad. I am grateful, though I think at that point I didn't see how grateful I should be. I completed my pulmonary critical care fellowship and didn't feel, after 6 years of postgraduate training. So I got done with medical school, went through 3 years of internal medicine training, then another 3 years in Memphis, Tennessee, with UT for pulmonary critical care. But even after 6 years of postgraduate training, I didn't feel like I was done. I just had a sense of restlessness. And that led me to go to my mentor and say, hey, I'm not ready to grow up yet. Screw that paycheck. Who needs that? Underpay me 1 more year. And so that's what I did. And crazily enough, I think if you see my paycheck, it actually shrunk. New York, they have this cost of living adjustments. I actually earned as a resident the most there as a PGY3. And then every time I took one fellowship, my pay went down. And then when I went for my last fellowship in sleep medicine at WashU, they capped it as a PGY5. So even though I was a PGY7, and so I took a pay cut every time I decided to do a fellowship, which was interesting. And but I was glad I was forced to do it because it was my year or the year before me that they actually stopped allowing pulmonologists to be grandfathered into sleep medicine. And so in WashU in St. Louis, the sleep faculty is under the neurology department. And I got my butt kicked because it was a completely different mindset to sleep. And I'm glad I did that because it was a very core grounding in understanding the basic of neurology and neuropath in terms of understanding disease processes and so on. And once I started my big boy job, I had that sense of restlessness about 3 years into it and decided to pursue my MBA at the University of Chicago. And
Hey, Dr. Barr,
yep.
tell them where your wife came in all of this and what she does too.
Yeah, so she's an internal medicine physician as well. We met when I was in fellowship, and I had the pleasure of actually being her attending, which is not pleasurable at all, because it's that 8 hours a day that I was interacting with her, where I was actually right, maybe, and then I had to figure out how to deal with the ramifications at home. But yeah, after I finished my MBA, I had the false sense of confidence to set up my own practice, which I did, and I'm grateful for my wife to allowing me to do that. because as a physician, she earned a decent paycheck, which means I could take risks with my career. And that's when sleep was born in early 2000s. And COVID hit and tele, became very much a commonplace. And we've grown since then. And I've had the pleasure of knowing Dr. Denbar and the rest of the team here. And I'm truly eternally grateful to Martin for educating me and spending time to kind of walk me through things. When we first got to know each other, he made a lot of assumptions that I knew a lot, but I was actually listening and learning from him, and then realizing, man, I've got so much more to learn about this space. And he taught me a lot of dental sleep and sleep medicine as well. So, like I said, we've grown. We see several thousand patients a month now, and we are close to in 50 states. We technically are in 50 states, and Texas Dental Sleep Services is one of our treasured referring offices. So let me just move on here. This is what we do essentially. We see patients because I was seeing a pain point in primary care offices, in cardiology offices, in psych offices, in dental offices. That was a bottleneck. The US produces about 150 sleep doctors a year, and there was always long wait times, and there's a lot of conflict of interest as well. What the dirty little secret with sleep medicine physicians is that you usually credentialed at a local sleep lab, and you get paid in reimbursement numbers about three times more to read an in-lab study versus a home sleep test. Yes, there's more data, but usually the data is crunched by your sleep tech, and you're presented a pretty nice little interface to review the data. But a lot of times they end up trying to get a patient into a sleep lab when they may not need a sleep lab. Home sleep testing grew in its commonplace, or how acceptable it was by insurances. And that's allowing us to see patients at a much larger scale, getting them through the process quicker. Because as much as people kind of pick faults with the home sleep testing, it has democratized access to care. And we do multiple nights of testing to make sure that we don't miss the diagnosis. Because I think if we don't do multiple nights of testing, women disproportionately get affected by being underdiagnosed frequently, because they may be in the milder range and there's night to night variability and you miss out a diagnosis. Because we are not just a sleep testing company, we are the medical practice powering this. All our notes are there. So when I read a sleep study, even though it's coming from a nurse practitioner who's ordered a sleep study for a patient, I can see what their note says, so that when I look at the sleep study, I have to figure out whether it is a false negative or not. And I think that's what is super helpful for us to understand the context compared to a lot of these large sleep testing organizations that crunch through thousands and thousands of sleep studies. The clinician who's working with the patient is removed from the person reading it. And I think that's where for us, everything is in under one roof. And we're able to see that to figure out like, hey, does this test result make sense? Do I need to go in and look at the and manually do an overread? And that's helpful because it helps patients reduce the time to get diagnosis, but also the cost. And let's be honest here, if patients see that, oh my God, the sleep test is negative, and I'm here gaining from the fact that it's a false negative, because guess who is going to do the retest? Us. That makes it another conflict of interest. So what we do is we try to ensure that we're overreading a lot of these studies when they come back negative, to make sure that they truly are negative. Because again, women tend to get disproportionately affected by this, and many of them go on with life assuming that they don't have an issue. I mean, the number of times we've come across patients like, yeah, 10 years I got tested. It was mild. I was told I didn't need therapy, or it was negative. And I was like, but you have the same symptoms from 10 years ago. Why would you? So, it kind of just puts in perspective that someone just read a sleep study and didn't really factor in the patient in all of this. So we do everything from online consultations, long-term care, efficacy testing. We manage therapy as well. If the patient is in severe range, we will manage that. We'll advise patients again, whether they come from a dental office or not. And we've lost a lot of dental referring offices because we stood our ground and drew the line in the sand, saying, hey, we will advise patients accordingly based on guidelines. If it's severe, we will tell them accordingly that, hey, the dental device may not be in the best interest, and we would recommend a CPAP. Generally, it's a conversation to be had rather than forcing patients down. And some dental offices say, no, you have to send the patient back to us. I'm like, but the patient, our notes clearly say the patient has a sibling or a spouse that uses CPAP and they prefer to use a CPAP. What do you want me to do? Pretend like I'm not listening to them? So we do end up explaining these treatment options to patients. Generally, when patients come to us from the other dental offices, first of all, they probably wouldn't have gone down the road of testing for sleep apnea if they thought CPAP was at the end of that road. And I think we have to be aware of that as well, so that not trying to force round pegs into square holes. And so we talk to them, and when they come back to us for the return visit after the sleep study is done, each patient gets a email with a PDF of attachment of treatment options, and we go through everything from CPAPs to dental devices to weight loss to the Inspire device, just to make sure that, hey, to level the playing field so that our providers as well have to then address questions that patients may bring up. We don't just try to, force them into one treatment or the other. But the idea is to have a good conversation so that allows the dentist or the dental office to screen more freely, because you're not worried about the hot potato, severe sleep apnea patient that may have cardiac issues that you're going to handle. Because you know that if this more you screen, whoever doesn't fit into the best case scenario for a dental device, we will handle that to manage that to get them on CPAP. So that gives you the liberty and the freedom of actually screening as many patients as possible.
I want to interrupt you for a minute and pay you a compliment.
Oh, thank you.
If y'all have ever had something stressful come up with any of the information you get back from the sleep people, Dr. Barr never gets angry. I've never seen him get upset. He is always very calm in his explanation, because we had one of those that I wanted to crawl through the phone and yell and scream. And once they explained it to me, I was like, oh, that makes perfectly good sense. And it was one of these that was a little more severe and really needed to be on a CPAP machine, at least at first. And I'm just very impressed with your team because they are always educating. We're all on the same side. There's no accusation. Of course, I was calling accusing, and I apologize. But y'all's team is very good at helping us learn that. So I've been very appreciative of you and your team, because most physicians do not do that.
Yeah, and that's what we're trying to do to set ourselves apart, because I think there's in this sort of age of Silicon Valley healthcare initiated apps and these sort of practices that come out as they're bringing in a lot of clinicians that don't actually are not really bought into the philosophy. So as a medical practice, I feel like just like y'all run your practices, y'all have your DNA stamped on it. We want to make sure that our DNA is stamped on it as well, so that we are doing things right by patients, because I don't think us as a virtual practice, we have a reason to exist if we cannot be better than the status quo. So we're trying, we're not perfect. We screw up often, and appreciate any feedback we get as well. So shifting gears a little bit to learning objectives, we're going to go through some of the sleep apnea symptoms here, and I'm preaching to the choir, but we'll go through kind of the less common ones as well, some comorbid sleep issues, then talking a little bit about insomnia, and then the follow-ups of what we do and how to best treat our patients. So first one, identifying sleep apnea symptoms. We all know what obstructive sleep apnea is. The desaturation is a fragmentation of sleep. So I always explain to patients there's two things going on. You have the hypoxic burden, you have the low oxygen levels, the triggering of that inflammatory response. That is one pathway that affects patients. And then the other pathway is a fragmentation of sleep, because the narrowing of the airway, the arousal to kind of restore muscle tone. And so they're both coming together kind of is like rocket fuel. But some patients are more predisposed to this, and some patients are more predisposed to the fragmentation of sleep. In any case, the treatment is really ends up being the same. So that's what's important for us, is to make sure that regardless of which one it is, that the treatment has to be optimized for the patient. And that's why I think me and Dr. Hathaway and even Dr. Stampy and Dr. Denbar, exchanging of notes and so on, to make sure that, hey, these patients are optimized. And we'll tell patients at times like, hey, listen, I don't think you need a retest at this point. The efficacy test that we normally schedule a 4-month follow-up after the oral appliance referral is made back to the dental office. Many times they'll say, hey, listen, you're nowhere close to being ready for this. There's no use to repeat a sleep study. You need to go back and speak to the dentist about X, Y, and Z. You might need some further adjustments and so on before you're truly ready. So treatment optimization is key, regardless of what sort of is affecting the patient, whether it's more the hypoxia versus sleep fragmentation. The goal is to get them titrated as quickly as possible so they start seeing the benefit of therapy. Otherwise, if someone that started the journey 2, 3 months ago and they're like, man, I'm a couple of $1,000s into this, and where I'm not feeling the benefit yet. So I think the goal is to work together so that we can get these patients through to optimization of therapy where they start seeing the benefit. And that's the whole idea, so that as a team, we can ensure that a patient that walks to a dental office unknowingly uh, with the sleep issue, coming out of that office feeling like their sleep issues, and man, they have great dental work done as well, have been resolved. And that's what I mean by a lot of dental offices, with hopefully with our support, can also position themselves as airway centers and screen as many patients to ensure that, one, that we are touching as many lives as possible. But it makes this worthwhile because we're not all charitable organizations here. We do have to keep the lights on. Common symptoms of sleep apnea, and probably some of the uncommon symptoms, audible breath sounds. I think one thing is we tend to mistake, or it has to be loud snoring, or a lot of times women will try to downplay snoring and all. It's a caveat here. I only when I have sinus issues or only when I'm really tired, fine. As long as I hear you make breath sounds or breathing sounds at night, that itself is indicative of a narrowed airway, because we don't have any breathing sounds we make that we are aware of during the day, because the airway stays wide open. It's only the narrowing of the airway, the vibratory sound that occurs because of a narrowed airway, that you actually hear audible breath sounds, light snoring, and then heavy snoring. But all these patients are at risk anyways. The witness apneas, it's like a 5-year-old can diagnose them. The waking up to urinate, women do that, men do that. Men get, told that it's a prostate issue. Women are told that their pelvic floor is weak because of childbirth and so on. Not true. Not everyone is weak. The body does heal itself. Frequently, waking up to urinate is a symptom, and I'll use that as well. So that's why when we do the initial history taking, all the symptoms related to sleep, it's clearly listed there, because that's my gauge in trying to figure out when they're on therapy, whether it's a dental device or a CPAP, have I truly improved their lives, their sleep? Have I optimized it? Because I think putting them on, and most patients their symptoms are here, and when they get down to here, they're like, oh my God, this is great. The question is, can I get it all the way down here? And that's where the symptoms are important to note down, because then you start going back to this. Okay, are you still having those night sweats? What about those morning headaches? Are you feeling more refreshed? Yeah, I feel better. Okay, good. But I think you might do even better because I noticed that you still waking up twice to urinate, or you still have, oh yeah, I do feel like I have a late or early afternoon crash. So these are clues that their treatment has not been optimized. So making sure that we reach the level where someone can feel like they've truly had the best therapy they can get. Because I don't want patients leaving my virtual doors and not getting the best care they have, because I think that for me is, I'm shortchanging someone's life. If I had the ability to kind of help them that extra little bit, that gave them that extra little bit in their lives, in the day, and in the quality of sleep, that I think we should all strive for that. The other symptoms, grinding. Oh my God, the amount of grinding in people, the bruxism that exists, clenching of the jaw. The more I know about this, the more I realize, wow, this is a clue. I mean, again, a lot of younger people, women have TMJ issues, have headaches, grind their teeth, and they go down this pathway of being told that they're just anxious people. Like, oh, you clench your jaw at night because you're just anxious. And I'm like, you're freaking asleep. What do you mean anxious about? There's no excuse why you should be clenching your jaw. But they're told these stories to kind of say, don't worry about it, especially from in the hands on the eyes or ears of a clinician that's not skilled. They're just going to put all these excuses into like, oh, don't worry about it. It's just you. And I'm like, all right, that's kind of weird, because don't you need to explain the symptoms? Patients waking up startled or in a panic. Oh, you're just waking up panicky because you're stressed at work or because you have anxiety. I say, you're asleep. You don't do that. And if you do that, there's something that's triggering an awakening. What is it that triggers an awakening? Sleep is just like any process, natural process. If I said that while you were taking a dump or number two, you'd stop halfway and not be able to continue. It's like waking up at night and not being able to go to sleep again. You're like, oh my God, that's something wrong, right? And so if a natural process stops and doesn't allow you to continue, there is something wrong. And same thing when you have awakenings and so on, is to figure out why. Patients struggle with poor concentration, memory. So all these talk about dementia and forgetfulness and so on. We have to start looking at sleep as the causative factor. Many of these patients have been undiagnosed for many decades. They get put on ADD medications, and now even pediatricians are slowly coming around to actually getting a proper sleep evaluation instead of trying to drug everyone to sleep. And we have to start looking at these sort of subtle clues. One thing is interesting is my own personal presentation of sleep apnea was night sweats, and as a pulmonologist, I was like, holy crap, I have tuberculosis. I've been exposed to a patient. Nope. I used to wake up with anxiety, morning anxiety. I used to love my mornings, having a cup of coffee, reading a book, catching up on my journals. And mornings became increasingly a stressful, like, oh my God, I have to get to work. I have this checklist of things to do. Wasn't due to that. It was my sleep apnea. And once I got that treated, night sweats went away and I wake up without anxiety. I love my mornings again. But these clues are subtle. And that's why I don't want you to kind of make sure that when you talk to patients is not to just highlight the big dramatic symptoms. But that's one thing I find very helpful is the medication list that I get from patients. As physicians, we get the medication lists. Our EMR pulls them in through a database, but we also ask to confirm with patients as well. That gives us an immediate idea about the clinical burden the patient faces, whether it's high blood pressure, anxiety, diabetes, and you're like wondering, why is this human being breaking down? What are we missing? Generally, it's a sleep issue that we've overlooked because no one's actually asked them these questions. And if you ask them, I'll tell you there's 95% of the time they have a sleep issue. And sometimes when I'm kind of feeling a little bit more brave, I will go ahead and joke with the patient. I said, you're based on your medication list, you have a sleep issue. Otherwise, I don't understand why your body's breaking down. You can't be that genetically deficient. And so, I think a lot of times just seeing that medical burden, that health burden that the patient carries is clue into something that might be missed over here. Comorbid sleep issues. So someone that has potential sleep disordered breathing, they also have a higher risk of high blood pressure, atrial fibrillation, type 2 diabetes, stroke, cardiovascular risk, mental health issues. There's so much overlap. We're looking at women's health right now and seeing that a woman's risk of sleep apnea increases threefold. And then the medication list actually sometimes explodes and goes up threefold as well, from not needing any medications to being everything now under the sun, and they have thyroid issues and all of a sudden they have anxiety issues and they need something to help them sleep, something to stay focused during the day, something to treat the anxiety. And then, oh, they have a touch of TMJ as well. It's fascinating to see that, once you see something, it's hard to unsee it. Just the way now I look at everyone's mouth or oral cavities whenever I'm just talking to a stranger and I'm like, oh, that's scalloping. Should I tell them now or later? Or maybe should I just shut up and keep it to myself? I don't want to impose. But there's a lot of cardiovascular risk factors as well, as you see over here. You probably would have seen as well recently a paper that came out that talked about like melatonin use and its increased risk of was it melatonin use? Yeah, I think it was melatonin use and the increased risk of like things like heart disease and stroke risk and high blood. All of this is likely patients self-medicating with melatonin and kind of papering over the cracks of sleep disordered breathing. And their symptoms or their risk factors for death are actually the same thing as sleep apnea. So you see the same sort of risk factors across insomnia as well. I'll show you in a little bit. And that's why I'll kind of talk a little bit more about that, about insomnia, the diagnosis versus the symptom. So, like I mentioned, it not only coexists with cardiovascular morbidity, but also mental health and ADD, dementia risk, and so on. And we're seeing that right now. So that's why, as clinicians in dental offices, you all have a unique position of actually screening patients at a much younger age. I mean, it's been so gratifying to work with teenagers and young adults because, when you change the trajectory of a 50-year-old, I feel great. I feel like a magician. But I mean, when I change the trajectory of a teenager or a young 20-year-old, I feel like a superhero because I'm like, man, can you imagine the effect it's going to have on this person's life? And so I think understanding the impact that we have. So I think setting up more active screening tools in your office, coordinators, your hygienists, and so on to kind of start that conversation with patients because it's likely not going to be the first visit or the 6 month visit or the 18-month visit, maybe the 24-month visit that you finally actually get through to them because they start seeing the connection between the health issues and what you've been peppering their ear with and dental hygienist have been telling them about sleep issues and how it relates to all of this starts clicking. And I think that's where initiating that conversation early on is super helpful because these patients, it's like a drip campaign. You got to tell them slowly, slowly, and when they're ready, they'll come back to you. Comorbid sleep disorders, other things like restless legs. I'll tell you this, I don't treat restless legs, not because I don't have to. Well, it's actually because I don't have to frequently. And the reason is this, a lot of restless legs is triggered because of a hyperadrenergic, hyper stress state. One of the most common things that is occurring to these patients, I mean, assuming you've ruled out any medications and so on that may trigger it, low iron levels, which happens in some women, for example, but frequently you find sleep disordered breathing triggers a stress response, and the restless legs frequently will get tremendously better once you get the sleep disordered breathing, which is the trigger factor. So, I just attended the Sleep Trends conference in Atlanta just a few months back, and it was a neurologist that was giving us a talk, and she kept about restless legs, and she kept saying this. She's like, sleep apnea is evil that you have to control first and check for first. And I'm so glad she said that, because in my practice, I just felt like I was a crazy person. I was routinely ignoring restless legs because it's going to be more medications for the patients. Yes, you're chasing this. Now, it's not that I don't have to treat it. If it's severe, I'll treat it. But I start looking very closely for sleep disordered breathing. So I'm looking specifically what's triggering this. I'm looking at the medication list. I'm looking at risk factors for sleep disordered breathing. The idea for me to present this to you all is to show you that even if someone tells you they have something else and so on, if it's a sleep disorder, they may all be connected. And that's where the connection is. So kind of make sure that you just say, oh, you have restless legs. Yeah, you kind of have, that's fine. I won't screen you. You're fine to think about like, all right, there is a connection. Same thing with periodic limb movements, which occurs primarily during your sleep. It's diagnosed frequently during in-lab tests. Again, there's not much treatment for it. They follow treatment protocols for restless legs when they're implementing it for periodic limb movement disorder. But the same sort of philosophy flows through for that, which is to make sure that you're treating the trigger factor. And frequently that's sleep disordered breathing. So take note of that, because this patient may present to you a little differently. All right, coming to one of my favorite subtopics here, insomnia, the symptom and diagnosis. And that's because I frequently will not ignore the insomnia, but look for the underlying factor for the insomnia. Now, I think, we try to impose these sort of things like, oh, quiet the mind. You need to wind yourself down. You need to take Ambien. You need to do meditation. I mean, again, sleep is a natural process. And if you had to do all these things for a natural process to take place, there's something unnatural about it. If I had to tell you to do the same thing to take a leak or to feel hungry or to have sex drive, you'll be like, are you kidding me? Like, what do you mean? And so, same thing as well with sleep. If you had to do all these things, this elaborate sort of routines, there's something functionally wrong. What tends to happen is, what my theory is, that a lot of patients do have an underlying risk factor for sleep disordered breathing. There comes a point in their lives where whatever happens, whether they age in a certain way, they go through menopause, they have a health change, that's when their sleep may worsen. So they have a predisposing factor already, a family history, a narrowed airway, and so on. Could be weight as well. But then they hit a certain age, and that's when the airway becomes a little bit more. And that's a precipitating factor, right? So you have that change in your health status, and that's when you start sleeping less well. Now, if you wake up once or twice, there's nothing that will stop you from turning around and go back to sleep again. Now, if you do this every night or every other night and you're not able to go back to sleep again, you start triggering in your own head this sort of stress response. Like when your eyes open, you're like, holy shit, I'm not going to be able to fall asleep again. That triggers your heart rate to go up, your blood pressure to go up. You stimulate yourself. Now, that is because what tends to happen is when you awaken or arouse yourself from a sleep disordered event, breathing event, you actually have a cortisol surge. Now, when you wake up a little wired but tired, and you've done this a few times, you know you might not be able to go to sleep again. It becomes a self-fulfilling prophecy. You end up not being able to fall asleep again. So the point of this slide again is to show you that some people presenting to your offices in your dental chair may claim that they only have insomnia, that they've been tested for this. Yes, you could say someone with really bad mental health may have this. The question is, why is someone awakening from sleep? You should be asleep. And when you wake up tired and you just have an arousal where you just turn over without the cortisol surge, your body's programmed to go back to sleep again. We also are programmed to produce less urine at night when we're asleep to avoid the disruption in our sleep. So the body is geared. Think about this. There's very few things in our lives that we dedicate a third of it to, and sleep is it. If I told you to work out 8 hours a day, you're like, man, the return of investment better be amazing, right? So same thing as well with sleep. You better wake up refreshed. You better be sleeping through the night. If you're not, something is amiss. So with insomnia, for example, there is a precipitating factor. And then patients start changing the way they sleep. They start being more anxious as the nightfall occurs. They start worrying about it. They start focusing about it. They don't go to sleep within 15 minutes. They trigger a stress response. They get nervous. Oh my God, tomorrow's going to be a crap show. I've got all these emails to respond to. Oh my God, I'm going to drop my kids off. So immediately, and then what they start doing is getting into bed a little bit earlier before the body's truly ready to go to sleep. We all have the ability to stay awake for about 16 hours a day. And you try to get into bed. Let's say you wake up at 6 o'clock and you go to bed at generally at 10, but you're having trouble falling asleep. Guess what you'll do? It's like, oh, I need to go to bed earlier because I need to take this seriously. The American College of Physicians say that you need 7, 8 hours of sleep. Holy crap, I need to do this. And so you end up going to bed a little earlier, which then causes you to actually go into bed too early and you're not able to fall asleep. And that solidifies the sort of cognitive changes that you're like, oh my God, I can't sleep. I'm going to lose track. They lose confidence. And that's when the triggering of the stress response continuously occurs. So they end up then developing comorbid insomnia. So not truly insomnia as a standalone diagnosis, but insomnia as related to something else. So I think that's something to take note of. They start using alcohol. They start using more caffeine during the day and not realizing as they age and as women start using maybe oral contraceptives, caffeine breakdown slows down. It affects their sleep at night. This vicious cycle continues and worsens and worsens and worsens. Comisa or comorbid insomnia. Now, this is something that I find very fascinating because, again, even if you take the underlying factor out of the way, which is sleep apnea, you still have this patient with some sort of dysfunctional belief, which is like, oh my God, I'm not going to be able to fall asleep. We don't like when we start treating a patient and they have risk factors of sleep apnea, we'll treat that. And then we start focusing on the insomnia once the sleep apnea is better treated, because that gives the patient a chance to actually change their behavior. Because if you don't change their reality, you can't change their behavior towards it. Because if you don't make them start feeling better, that, oh my God, okay, maybe I see the curtains being pulled back. Oh, I see the light at the end of the tunnel. I do see improvement. Maybe my sleep can be changed. And that's what allows us to then start making some real difference with the insomnia therapy because they end up going to bed earlier. They spend more time in bed. So we do something called brief behavioral therapy of insomnia, which is where we start practicing a little bit of sleep compression. It's like, hey, listen, you don't need that much of time in bed. But you can't do that if you don't treat the underlying problem because the patient will keep going back to the fact that they're not waking up refreshed. And that's because you haven't changed their underlying fragmentation of sleep yet. So this has to be done hand in hand. You treat the sleep apnea, then you treat the insomnia so that patients actually see the benefit and understand that this is actually working. And now I do have the confidence again and compressing my sleep doesn't translate into a hell of a day the next day because I'm in bed less instead of more. I thought I was supposed to take it seriously. So I think that allows us to make sure that insomnia is also treated well. But one of the things most women get misdiagnosed because women actually use when they have sleep apnea, a male and female, males are brought in by their wives, told they snore loudly, or they complain of daytime sleepiness. Women tend to use words like fatigue and they have headaches or they feel unrefreshed or they have insomnia. These are exact words women use to describe the symptoms when they have sleep apnea. And men use the more traditional terms that we are more tuned to. And so that's why women tend to go down a completely different pathway. So the one thing to understand is as well is that, this idea that if you have insomnia, you have a difficulty initiating sleep. You have difficulty initiating sleep, you can't have sleep apnea. That is not true because whenever your airway narrows, it triggers an awakening. And if you're in light sleep, the only awakening is wakefulness, not deep sleep to light sleep. So patients still do wake up from unable to fall asleep because of sleep apnea. They feel like they have to hit a wall of exhaustion. Otherwise, they keep getting awoken to keep them breathing. So they feel like, and that's why a lot of times my red flag in my head is, oh, I'm not a morning person. Another one is, I'm a night owl. Oh, I love falling asleep with my TV on. These are all, oh, I sleep on my belly. I'm a light sleeper. These are all red flags because I'm a light sleeper means you're not getting to deep sleep. Why aren't you getting to deep sleep? What's stopping you from that deep sleep? Now, if it's not a medication side effect, chances are sleep disordered breathing. There's all these sort of red flags. They sleep on their stomachs. Why do you sleep on your stomach? As a pulmonologist, as the or retired pulmonologist, it's the most unnatural position to sleep in because your chest wall doesn't expand naturally. But what it does do is allow your jaw not to be all the way back when you're sleeping on your back on the front. It just stays more forward. So you actually allow better breathing. So when they say they're light sleeper, they're belly sleepers, I'm like, I'm a night owl. Like, why would you be a night owl? That goes against how our bodies are built. I think there's a lot of misunderstanding. I think the data out there, my theory is that a lot of patients actually have sleep disordered breathing. We've misdiagnosed them and we think they have insomnia. We think they have this, morning, daytime and morning larks and nighttime owls and so on. I think these are just miscategorizations of patients who actually have a sleep disordered breathing. We did not know this before because we couldn't do multiple nights of testing. We couldn't, and home sleep and in-lab testing was expensive. And in-lab testing, we now understand as well, has something called the first night effect, which contributes to false negative rates. Again, disproportionately affecting women because usually women may be on the milder side of things and there's night to night variability, especially that's what the first night effect is. You don't sleep your normal way when you're in a new environment. And so a lot of times patients get mislabeled or misdiagnosed. So I think a lot of these patients actually do have sleep disordered breathing. So just understanding that the pool of patients that you screen for, just because they think they have insomnia, that may just be a symptom and not a diagnosis. Daytime consequences of insomnia. I just showed you the slide for sleep apnea, reduced motivation, similar depression, impaired performance, focus, ADHD, for example. They're more recluse, they're tired, they just want to stay home. The fatigue, the malaise that goes on with that, the dementia. A lot of this that we see from insomnia in terms of their daytime consequences overlaps so much with sleep apnea. And so to imagine two different processes causing the same risk factor, same sort of diseases, kind of makes you think, are they really two separate processes? Or may they really actually be commingling or comorbid in some form or fashion? Clinical follow-up. This is the part that you optimize. And this is how we try to work with a lot of dental offices is try to make sure that you have a collaborative practice that's working with you, that's working alongside you, that's working to support you. That's, because we know it's a mutually beneficial relationship. We know the better job we do makes you look good, and the better job you do makes us look good, right? Because again, we don't want to recommend oral appliance and then the patient comes back to us upset. Same thing is we don't want to recommend CPAP and the patient comes back to us upset. So for us, it's in our interest as well to make sure that patients are in good hands. And that's why working with TDSS has been great because I think everyone speaks the same language. Everyone's interested in doing the same thing, which is to do right by the patient, to ensure that we actually are trying to optimize their sleep. Because again, walking into a dental office and walking out with great teeth and great dental care and great sleep, I mean, that's a huge bonus. And that's how we do this is when you screen a patient, send them over to us. We do our thing of getting them booked. We verify the benefits, making sure that we're in network. We let them know if we're out of network. We then schedule that initial visit. We document the symptoms, educate them on how their medication history or their medical history connects with their sleep issues. Sir, it's not just a snoring issue that our wife is bringing you in here for. It's more than that. And I think that's where educating the patients allows them to actually go through with testing. Because I think understanding why and getting excited about the fact that this is just more than snoring, this could be life changing. That's why that first visit is so important to kind of get the grounding going. And then we do the sleep test. Come back within a matter of weeks. We do the follow-up visit. We discuss treatment options. We prescribe oral appliances. And if for everyone's benefit here, we do actually prescribe more dental devices than we do CPAPs. And the crazy part is we actually make money from CPAPs. That if that gives you an indication of how balanced we're trying to be with patients, because we're trying to avoid any sort of conflict of interest. We're trying to weed out any conflict of interest. We even send patients to in-lab tests, but not because we make money of it, because we're not credentialed in sleep labs. We don't want to either. We send them down to sleep labs because they clinically need it. So whenever it's needed, we do it, and that's what I call alignment of incentives. So it's not a crosshair that you're against the patient. And so when we see them and diagnose them, we do multiple nights of therapy so we don't miss the diagnosis. We then discuss therapy options, put them on therapy, whether it's a dental device or a CPAP or start CBTI, if it is truly insomnia, or treat their restless legs, or just some of their medications that may contributing to some of their daytime fatigue and sleepiness. And then after that, co-manage these patients, because we automatically, when they refer a patient back to you, we send them a 4-month follow-up appointment, because generally we found that ends up being just about the average time most patients get the device, get it fitted well, get it titrated, and they're ready to discuss about efficacy testing at that point. Again, we set the 4 months because not all dental practices are TDSS and well trained in understanding the basics. Some dental offices will just sometimes just tell a patient, okay, this is your tool, go back home and I'll see you whenever you need us. And so we have to step in at that point. That's why we have that sort of checkpoint at 4 months. We also send patients a message after 30 days. Have you met with the dentist? How's the experience been so far? Do you need an early appointment to discuss any issues? Because we find as well that patients may hit a roadblock, and we want to make sure we capture them back to ensure that, hey, if there was a misunderstanding, if you felt the cost is too much, or maybe this wasn't explained to you, we want to make sure we do that better. So that's our current workflow, and that's how we try to collaborate with between us and dental offices. We don't have too many more slides, but I just want to touch on home sleep testing because I know that's a common question. We use primarily type 4 devices. We use the EnsoData HST or PPG. It's a user-friendly, it's a wristband, an oxygen monitor. It's an app that they download. We do 2, if not 3 nights of testing, and we try to ensure that that allows the patient. And we always tell patients, if you've had a anti-grinding or anti-snore mouth guard, not to use that during the test itself. We generally encourage patients to, if they drink alcohol, continue as their habits, usual routine. We recommend as well that if you're on certain medications to help you with sleep, don't rock the boat, don't change anything. Just test the way you normally sleep, because that will guarantee us more realistic data and data that is more reflective of a patient's actual struggle or what's going on with their lives. And so we do use type 3 devices for patients who don't have smartphones or not technologically savvy. We do use the type 3 devices for those patients, but 95% of our patients get type 4 devices. And so that is also, a lot of it is cloud-based. The results are released to us for interpretation before it even hits our doorsteps again. So it allows us to get these patients seen. And then, even before the kit has hit our office, we've already interpreted the results, send them a message to schedule a visit, and maybe even seen the patient before the devices come back to us. Again, this works for some patients who are Johnny on the spot, some patients who are a little bit more relaxed. They take a lot longer to return the devices, and may need a little prodding to kind of get this devices testing done. CBTI, as I mentioned earlier, is used for insomnia. We do a lot of sleep restriction or sleep compression. We do stimulus control as well, which is primarily about waking up at the same time every day. Because this is part of that, the CBTI uses cognitive and then behavioral therapy. We don't do as much of the cognitive therapy because we're not therapists. We do a lot of the behavioral issues that may affect that. So less time in bed instead of more time in bed, and then trying to wake up at the same time every morning. And like I said, I find this a lot more effective if you actually look really hard for sleep disordered breathing. That's going to be key right here. Otherwise, a patient doesn't just decide that they have insomnia. Yes, there can be other reasons for it, but there's a triggering factor, there's a perpetuating factor. And usually the perpetuating factor causes them to continue to be in that vicious cycle. So a lot of it's sleep restriction and stimulus control are the core of brief behavioral therapy. So there's no cognitive in there. That's just more the behavioral therapy that you can implement to help patients actually sleep better. Follow-up protocols, we recommend patients get check-ins regularly with the dentist after y'all get set up, and y'all have your own protocols. Whether y'all feel the adjustment of the mandibular device based on symptoms, whether it's a snore lab app, whether it is based on a high resolution pulse oximeter. I think the tool for y'all use whatever is most comfortable. For me, I can tell if a patient needs retesting or not because y'all bundle a lot of times. I think the high resolution pulse ox is bundled into the whole program. For us, the home sleep test costs the patient a significant amount of money. So we don't normally want to do that until we know the patient's ready. So we always go by a lot of it as symptoms. If we see again what they came in with has only been partially addressed, we'll encourage them to kind of further titrate with the guidance of the dentist and to go back to the dentist's office. Hey, when's your next follow-up visit? Oh, I think you need to go back sooner. No, that's way too long. You need to go back sooner. So I think that check-in with us as well at 4 months is super helpful because that allows us to nudge the patient along, especially those strays that forget what you told them during that visits, and they need to kind of be brought back into the farm. And then we do annual visits after that. Once we feel like, hey, everything's looking good, we'll see them back every 12 months. I think that's good care because sleep is a continuum. It is a chronic disease. It is not something you switch on and switch off like surgery. You take your gallbladder out. Oh, you don't have a gallbladder problem anymore. Sleep will change. And so that's why annual check-ins are super important because something else may have crept up. I think they may have a life issue. They may have a health issue that then cause their sleep apnea to worsen. So that dental device may have been titrated appropriately a year ago, but they may have had maybe heart failure. They may have had weight gain due to depression and so on. And these things can tip them over and cause them to worsen again. So checking back in for us is what we regularly do as well. When to refer to us, I think anyone that has any risk factors for sleep disordered breathing, whether it's grinding, whether it's poor sleep, I think I have purposely not included any sort of questionnaires here because I don't trust any questionnaires. None of the questionnaires have been helpful because the stop bang works in a certain population for preoperative reasons. The Epworth Sleepiness Score does not capture a lot of our patients. I don't believe it unless it's high. And the problem is that if that's the case, then it's useless to me because it's not going to change my clinical judgment. I'm going to believe it when I want to believe it, and I don't believe it when the number doesn't make sense to me. And frequently the number doesn't make sense to me. Again, patient's experience is very different than the questionnaires you ask. And so that I think is where the gulf is. I think that if you had two questions to ask, it would be, are you sleeping well? Are you waking up refreshed? Simple. And you can teach anyone in your office to ask those questions. It's not clinical. Is that they say they're not sleeping well, they're not waking up refreshed. Any no answer to either one deserves a look again and say, hey, listen, let's have a see and let's go to the back of your throat. Do you have any risk factors and signs in the dental cavity about sleep disorder breathing? Because then frequently you'll find one. So no, I don't generally use questionnaires. We do fill in the Epworth sleepiness score when insurance puts a gun to our head and say we won't pay you until you get us that. Fine. But apart from that, we find that of limited use. Snoring, great. Like I said, a lot of the symptoms occur, and that the common symptoms of this common disease or this uncommon symptoms of this common disease. The problem is this disease of sleep disorder breathing is so common that even uncommon issues or uncommon symptoms are pretty prevalent if you're looking for it. All righty. So to kind of wrap this up, I think a lot of sleep apnea remains undiagnosed. I think the dentist is in the best position to diagnose this. I don't believe any physicians will should doubt that. And I would encourage more dentists to kind of take this pathway because you are missing on a huge opportunity, both financially and career fulfillment wise. I think this has been something, like I said, I've left behind the critical care. I loved it, loved the adrenaline rush. But man, making the difference in someone's life like this gives me goosebumps and I love it. And just think about it in terms of the medical burden, the things you can change with a human being. And changing because there's so much of healthcare right now that's so medicalized, it's so much medications that more this, more that. But in actual fact, if we go back to the basics and say, hey, listen, what do you need? You need good sleep, you need good mobility, you need good nutrition. I can't affect mobility, I can't affect nutrition, but man, I can affect your sleep. And I think that's where when you start seeing the dots connecting with the human being and saying, hey, your high blood pressure, hey, your anxiety, hey, your TMJ, these are not separate things. These may all be related to one thing. I think that's what captures the attention of the patient because everyone looks for the same thing. They want better health. They want to live better lives. And frequently they get treated like cattle and not as human beings. And it kind of goes against what I'm taught. And I'm trying to bring that value to sleep care and hopefully working with dentists like yours in your office, I think has been a great pleasure of mine. So in wrapping up, I thank you for your time today. I'm going to open up the floors for a Q&A, and I will shut up at this point.
Dr. Barr, that was amazing.
Thank
Thank
you.
you so much. I have some questions for you. If y'all want to put your questions in the chat, can you see the chat too, Dr. Barr?
Uh,
If people type in it, will you see it? Or I can just read them to you as they come across.
you can read them. I can't see them
Okay.
right now. Yeah.
So I have three questions. You can address them in any order. We want to know more about how you're testing children, like because kids are always kind of scary. And
Hmm.
so we need to know if we screen them and see there's issues and we do our usual referral, what do y'all do? And then, what will we need to do to help you? Because I know we're not always putting appliances in there. And
Hmm.
then my next question is I know that sleep, your company is working on some new projects and ideas like adding nutritionists and things like that. So we'd like to hear more about that and tell us about your podcasts and courses that you also have for us to go learn more.
Okay, so let me address the first one. I think pediatrics has been, I mean, in fellowship, pediatric is a core part of what we do. But then when you come into practice, there's just so many adults that walk in your office. But the more we've treated adults, the more they come. And again, I think it's part of what you said about the education. Once you educate the patient about how this is all related, they start seeing how it's affecting their kids. They start understanding that, oh my God, this is my child's issues may be related to what I have as well. And we started kind of having to look at pediatrics. So our practice actually sees teenagers routinely, 13 and above, into adulthood. And so a referral made has we have no issues with that. We will follow the same protocol for them, see them, test them. Now, the sleep imaging is FDA approved for anyone 2 years and above. So the sleep imaging is what we use for all our pediatric patients. On a case by case basis, I will personally say I don't want to impose this because some people, not everyone's comfortable seeing anyone 12 and below. I will generally see those patients. And so the staff will then alert me to add this patient on my schedule if they're below the age of 13. But generally, we will see them. We will put them through the sleep image ring, get the testing done, same multi-night testing. Obviously, when it comes to therapy wise, we always send them back to the dentist to kind of understand what the treatment options are. But I think the idea with pediatrics is you can put them on a CPAP first because that way they get better, they start feeling better, and then you can then slot them into the office of ENT, or you can slot them to see a pediatric dentist who might want to look at certain oral expansion procedures. Now that's been kind of on the fringes, and I think it's becoming a little bit more known and thought of. My son is going through that process right now as well. I hope it's the right thing because I see him doing the same thing as well. So I think the treatment pathways do differ, especially in teenagers and kids, because there is the ENT addition to that, along with potential oral expansion therapy, which for adults we don't really think of or do, and ENT is less useful. Multiple studies have shown that. So I think, just understanding that we are able to see teenagers because they're pretty much, in need of help. They can communicate what they have, and they're so great with CPAPs. I mean, once they're on it and they actually feel better, that buys us time until they hit the age of 18, where we can consider an oral appliance. Again, I think in the hands of a good skilled dentist, they might be able to apply something a little sooner if they feel like the bone growth has developed. But I leave you all to decide on that. Did that answer the question on pediatrics?
Yes.
Okay. Um, Podcast, we do host regular webinars. We do I think we have a lot of great people coming by. I think the next one on we have is Dr. Kevin Boyd in May. So I'm excited about that. His reputation precedes him. I'm a little nervous about that as well. But we'll send out our emails. It's on our LinkedIn profile as well. We'll send out reminders as well when that happens. But we do this at no cost because we feel that we need to facilitate this discussion. We need to facilitate understanding. I think the old way of doing things was, people in the healthcare side was like, oh, I'm the gatekeeper. You go past me before I'll give you the answer. And I think we're trying to facilitate this discussion so that it becomes more of a discussion about, all right, this is what we know. This is why you should get treated. Now you don't have to come to us to get the treatment, but this is what we're trying to do to educate everyone and try to raise awareness as well. So we do host those webinars, and I think it's been fun, and that's the only reason why I do this as well. You asked me to come here, and Dr. Denbar has taught me, and I think that's been something that I've learned so much from as well. So hopefully today has been positive on y'all as well with the information I've rattled off at breakneck speed. So yeah, I think that was the second question. What was the other question?
The one about what y'all are working on, you had mentioned something about nutrition, adding some other referrals that you can then point people to.
Yeah, so we haven't dabbled as much into nutrition as opposed to supplements. We're trying to evaluate, especially in women's sleep health. We're finding that as they hit menopause, there's a lot of misinformation out there. There's a lot of quick fixes. And I think we're trying to ensure that we are at least providing a curated list of supplements that women can access to that co-treat some of their sleep issues, but knowing that we can also treat what's actually going on and then kind of supplement that. So we haven't looked as much into nutrition as opposed to supplements, and I think that has been eye-opening as well. Because I used to kind of just think, oh my God, more supplements, more medications. But again, I think to support their health as women's health, supplements have been really beneficial. So we're looking into that a little bit more. Haven't really started that yet because we're cautious about putting our just jumping on the next thing. Even for us, weight loss, at one point, we were this close to start prescribing like the GLP-1s, but then we realized that it took us away from what we know best. And we were cautious about trying to make a quick buck and not actually being the stewards of good care that we know we should be. And we want, and I guess we decided to stay in our lane.
Well, I love that.
So I noticed a message from Dr. Essick, and I've asked everyone to go ahead and unmute if you have any questions.
I was going to
But
let Dr. Essick
but
ask that
yeah,
himself.
but Dr. Essex, why don't you go ahead and ask your question?
Okay, great, great. Thank you so much, Dr. Barr. That was an excellent presentation. I really enjoyed it.
Thank
So
you.
I had a question about the 4-month assessment of the efficacy of the oral appliance. For those patients for whom you order a follow-up home sleep apnea test, about what percentage are found to be adequately controlled by the oral appliance? And if they are not adequately controlled, how does the additional titration and retesting work in your paradigm?
Good question. So I think the data may be clouded by some offices that ask the patient, the dental patient, or the patient that comes back to us saying, "Hey, we need a retest now." So in those patients, we normally follow through with what the dentist office is telling the patient to do. We're not going to fight it, even though I think the patient may still remain symptomatic. I believe that data point that they are searching for, the dentist office, is to validate whether they're moving in the right direction. So sometimes we end up testing patients, even though now, if a patient comes to us and they've not been preconditioned by the dentist office, we will kind of retest them based on symptoms. Now, again, it depends. The clinical context is, if they've maxed out or near maximal, or they're having trouble and they can't titrate anymore, then we have to do the efficacy testing. So I think that result is going to be clouded by what the patient goes through, first of all. So it won't be a fair assessment. But generally, I find that the first testing, I would say probably about 50% come back, and that's a very rough guess, come back as still being positive.
Yeah, that sounds great. Do you find that the insurance companies are paying for multiple home sleep apnea tests for this final adjustment if needed?
And I think that's where we've we've done, I think, a decent job of documenting the need, making sure that we say retest on our appliance to confirm efficacy. I think the documentation has helped us get paid. And we're not abusing it. We're not just like, oh, every month get another test. I think sometimes people see the gravy train and everyone wants to get on it. We're trying to build a sustainable practice, so we have to make sure that we do things right and we'll justify the sleep test. So I think the documentation, insurances have pushed back when the retest is within a month. A lot of private insurances, not so much Medicare, but private insurances will not pay if the retest is within a month, and that's pretty pretty reasonable thing. Only thing is sometimes if a patient has a false negative and we reviewed the data and I'm like, I cannot extract any more events out of this data set. And we ask them to retest, we have to wait a full month before the insurance will, and then we document that we think is a false negative and so on. But generally, we have gotten paid because we've documented adequately that a retest or a efficacy testing is needed.
Okay, thank you.
No
I got
problem.
it. Can you hear me?
Yes.
Oh, okay. I got a couple points. One, when I'm doing titration, I'm not going to send them back to you for any testing until I've got a good 3% desaturation indices, normal CT90, and a normal resting pulse rate and pulse rate variation. I'm getting quite a few patients that have normal CT90s desaturation indices, but their pulse rate's between 90 and 120. And even though they're still feeling relatively better, so I continue to titrate with that. Another aspect is that on the pediatric side, I'll treat patients down to 16 if they've got fairly advanced eruption patterns. I just had a case, there's an awful lot going on in the field of dentistry with what's called MARPE, palatal expansion. And the issue with that is I'm not sure how many people know of a gentleman named or a doctor named Bill Hang. He's one of the real world experts in orthotropics uh, and airway-centric orthodontics. And he taught me kind of a very useful term, and it is that you can't cure an anterior posterior issue by going laterally. And a MARPE procedure or palatal expansion, particularly on adults, it's a static procedure. But with the aspect of the aging process, you're still going to have issues. Whereas when you're using anterior positioning, one, it's more conservative using a mandibular advancing device, and you can go ahead and continue treating your patient as a part of the aging process. I had a patient who was 16. They wanted to do the MARPE, orthodontics, and then MMA, maxillomandibular advancement on. I had an oral surgeon from Dallas referred the patient to me, really nice kid, and very heavy ADD, ADHD, never was breastfed. And so we went ahead and did the appliance on him and got his AHI down to 1. He's completely controlled simply with the oral appliance. and we're going to be doing myofunctional therapy on them in the very near future. So the other aspect is Eric and I are putting together a myofunctional therapy program
Mhm.
for our doctors to be able to utilize, and I'm really excited about that. I've already written the program. Eric is editing it, and we'll be getting that on board soon, probably by the 1st of June and first to middle of June.
Excellent. Thank you, Martin. You mentioned a myofunctional therapist. So I had a patient recently that was a challenging patient. She gave me a poor review on after our first visit. And I say a poor review, I mean a 4 star. She felt I wasn't giving enough, not listening to her enough. But she had a fascinating story. She's a myofunctional therapist, got a dental device, got tested 2 years ago, said everything looked fine. But she had this very uh, classic sort of awakening every 90 minutes. And I was like, that, and she said, I tried CBT, I tried this, blah, 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 blah. And I was trying to explain to her, I said, this 90 minutes is, there's something with that. And, obviously that coincides with our 90-minute REM cycle. So I said, I think you're going to REM events. And I think this may be it. She didn't believe me. So we just worked on a few other things and told her to come back. And that's when she gave me the poor review, like I wasn't listening to her. Got it after 2 visits. She finally agreed to get tested for on the third visit, which I did, and she had a positive result. And then now she's kind of open. She's gone back to the dentist to get the device readjusted. But just you mentioned the myofunctional therapy, and I think oral appliance. I think like that's why I think the long-term care is important as well because people change as they age, and I think that follow-up visit is necessary. A lot of dental offices sometimes will just go, yeah, just come back to us when you want to. And I don't think that's good care because there's an aspect to this that still needs, that actual check-in as well. But thank you, Martin. Question?
Dr. Barr, I have another question. What would what events would trigger you to conclude that the patient would be best treated on combination oral appliance and CPAP versus an oral appliance alone?
I think it depends on whether they came to us from a dental office. If they come to us from the dental office, um, and they opt for a dental device, frequently, even if they are in the severe range or mildly severe, and when I say mildly severe, I mean like in the low 30s and so on. And sometimes what's a little misleading is, a 4% mild, like in the 4% a rule, and you're in your AHI of 32 might be a 45 on a 3% score. But generally, someone truly at a 3% mild severity, like in the 30s, low 30s range, we'll still talk to them about dental devices and explain that, hey, this might work, might not work. And I think these patients, or the other group of patients that are at risk as well, are those that have truly severe, like in the 40s and 50s range, and they have had such a bad experience with the CPAP device that they don't want to. Well, I think these patients are the ones that they get started with the dental device and realize that when we retest them and if they don't get completely addressed, whether they've had a poor experience with CPAP before, I think they're more willing to come around and actually get a combination therapy. So these two patients, I think, groups are the ones most likely to get a combination therapy device. Generally, from us, if they start off with the CPAP and they're severe, and they don't, generally the severe ones actually do tolerate it. Is the mild to moderate. We normally switch them directly to oral appliance. We don't even try combo therapy from a CPAP to combo therapy if they're not tolerating it. And I can't imagine why. It's interesting. Maybe the more severe they are, that the CPAP gives them enough benefit, even though the experience hasn't been great, that they feel that they don't switch. Well, it just got me thinking. But yeah, generally, I think if they're on a CPAP, mild to moderate, they're not tolerating it, we will switch them over to our appliance, not combination therapy, because I think they probably will be better served in a dental device. Does that make sense, Dr. Asik?
Yeah, yes, absolutely.
I have a question.
Hey, Dr. Bansal.
Hi. So, You mentioned after menopause or during menopause, there are a lot of females that would complain of tiredness, bad sleep, poor sleep. And I was reading on it, and it said there's a lot of chemical changes, and the chemical signaling is off during menopause. So I was wondering, do any of these females who complain, who were okay probably until the menopause and then it started, do they ever go back um, to be able to sleep without a mandibular advancement device? Um, that means, does the sleep ever goes back to normal?
So what we find is, and I'm not a menopause expert, actually, our chief medical officer is certified in obesity medicine and menopause care. So she would be a much better person to ask. But what she's taught me, what I've learned from her, so not to misquote her, I think during your the perimenopausal initial menopause phase, there is a lot of fluctuation hormonally and so on. So a lot of times the symptoms are there, and it's the sweats and the irritability, and then the sleep. What I find is the sleep doesn't get better unless you treat it. And I think that's been the issue. People will get over their night sweats and so on, but the sleep issues persist. I think the sleep issues are a my personal theory is that uh, sleep disordered breathing is kind of that trigger that forces us to age or have a decline. And the only reason why I feel that or think that is as a critical care physician, I've been there when patients are dying off the ventilator, and I'll tell you this, they sound exactly like a sleep apnea patient. I mean, when someone exits the world, they sound exactly like someone with sleep apnea. And that got me thinking, I was like, I think this could be what triggers the aging process. And the way it's related to so many organ system failures that we're seeing now as part of aging, whether it's dementia, high blood pressure, heart disease, mental health issues, and that, all these things, blood pressure control, diabetes, we're seeing it touch so much that to answer your question, I think the hormonal surges may present with certain symptoms, but the sleep issues are going to stay and need to be treated lifelong. Unless, of course, let's say they were overweight before and then through menopause, they started taking control of their lives and started changing and maybe address some of their risk factors. I would say that, and if they remain symptomatic, I'm always of the philosophy that if you have sleep apnea and you have sleep symptoms, I'm not going to blame anything else until I am confident that I have treated you well, that I've done my best to address those symptoms. And I think that's kind of the patient ownership that I was taught through training, and I appreciate my mentors for that. So I mean, I think if you remain symptomatic from sleep issues, even if you have an oral appliance, I'm not going to necessarily blame the hormonal surges because it's too easy intellectually to blame something that you're not familiar with. And I think we've done that at the detriment of the patient. So I think whenever you have someone who's going through menopause, who's you've addressed the sleep, if they have continued sleep issues, we should continuously look for reasons why. And I think that's where the optimization come in. So you just don't blast it with like an Ambien and good luck and Godspeed. Hopefully that answers your question, Dr. Bansal.
Yes, so an extension to my previous question. Whenever I see these ladies, their apnea is not too high.
Mhm.
It's right at AHI about 5 or even
Mhm.
below, but they'll still complain that they can sleep, they're not rested, they're just tired. Um, and then my dilemma is, should I tell them, okay, you need a sleep device, or be like, no, you're fine, but they do have a complaint.
Yeah. If you have, so, that's why sometimes I get asked these questions like, is an AHI 4.5 normal? The answer is I don't know. It really depends on the human being. It depends on how that number affects them. If they remain symptomatic. So if I retest someone, and that's what I was, Dr. Essex question earlier about, if you retest someone and if they're, how many you find positive and negative, if they remain symptomatic at 4.5, even on the dental device, I would not be happy with that because there's something. That's why I look at the nocturia and all the symptoms, because you just say these are all clues that telling me that something else is going on. Yes, this human being could have a prostate issue. Yes, this human being could have a hormonal issue. But if I'm attributing this to sleep apnea, then even a 4.5 may not be adequate. So to be treated means it needs to be, that means it might not be adequate for them to feel better. They need it lower. My philosophy, and this studies as well. So the severity of your sleep apnea is super misleading. That's why people don't like the AHI so much. But I'm of the philosophy that it's a dumbed down tool it's a yes or no. It's easy for someone who's not very skilled at it to understand that it's positive or negative. But I think from someone more experienced and someone who does this often, we know the flaws with that. So I think someone that, and like going back to what I was saying, there's no studies that have shown that if you have mild sleep apnea and severity, that your symptoms are mild. Now, they have proven that the more severe the number of events you have is related with higher risk of heart disease, stroke risk, and so on. But in terms of the burden of symptoms that a human being carries, someone who's mild, HI 5.1, 5, 4.9, could experience the same amount of symptoms as someone who has the AHI of 15. So there's no relationship. So we always have to look at it with the lens of what the patient struggles with. So if they have symptoms and they have a positive test result, I would address it with treatment because that's the only way we'll ever know. Otherwise, we risk of, and that's why I said 10 years ago, I'd have a patient who tells, oh, I was mild and I didn't need treatment. And I'm like, oh, shit. Because 10 years ago, we could have changed their trajectory. And now they're with their high blood pressure and chronic kidney disease and so on. It is a missed opportunity. So I would definitely treat because the honest answer is we don't know how it is going to impact the human being. The number itself does not convey the struggle that someone faces and whether that's attributed to sleep apnea or not. Because if you think about the HI of 5, and I always do this with my patients, especially in the ones who have mild results, HI of 5. I'll say your HI is 5, which means you had 5 breathing events an hour. Now I said, this is mild, but let me put it to you in a different way. Every 12 minutes, your breathing disrupts your sleep. Now, does that sound mild? It doesn't. And that's because then someone realizes, like, if I nudged you and awakened you every 12 minutes in your sleep, then it explains a lot of your symptoms. That's why you don't wake up refreshed. So I think adhering to a number and not looking at it and combining the clinical aspect of the patient, I think does the test no good and the patient no good at all. So that's why I think we always have to match those two things. I am very aggressive about treating even mild sleep apnea because the honest answer is I don't know the effect it's going to have on you. It could be great. I just don't know. And I don't want to be the person that tells you don't worry about it because I feel obligated to explain to the patient why they have a sleep issue. If you're not sleeping well, then if I downplay the AHI or the sleep study and says I don't think that's causing it, I better damn well have a good explanation of why they are symptomatic. Then what is your answer? And if the answer still comes back to the sleep apnea, then treat it because otherwise we're not going to know. Hopefully that explains the answers your question.
Yes, sir. Thank you.
All righty. I don't anything in the Q&A